I'm a cardiovascular technical consultant for Materialise, and I'm responsible for the software Mimics Enlight. So Mimics Enlight, I'm going to see that my screen. Yeah, there we go. Mimics Enlight is a 3D planner for structural heart procedures. And you can already see a little video here, and it contains a hollowed model of the left heart with a calcified mitral valve and a SAPIEN S3 in place. You can also already see the neo-LVOT calculation. Now, we really believe that bringing 3D value to the TMVR market can really help the field forward. Now, you can wonder, 3D, is it really needed? Is it really something I should invest my time in as a clinician? Or you might even think that you actually already use 3D. Now, there is a big difference between the 3D that is there on the market and the 3D that is in Mimics Enlight. And that's visualized in this slide. So on the left side, you can see a volume rendering. And on the right side, you can see a CT-derived 3D model. And I want to start off with this because it's a very important principle behind the software. Now, volume rendering, it gives you a visualization of a 3D heart model. So it's actually a stack of CT images, and it gives you the impression that you have a 3D model of your heart. However, when you will do a measurement on a volume rendering, you will still do it in one plane. The difference is that in Mimics Enlight, we really create that 3D object from your CT scans. So we create a 3D model like you have it in reality, making it possible for you to do your 3D measurements directly on that object. Now, this means that you can measure a circumference, a diameter, the distance from your papillary muscle to your mitral valve, anything that you think is needed. It also gives us a possibility to go for automation and for AI and to speed up your procedure such that you can invest your time in the most important things. Simulation is also a next step. If you want to do tissue deformation, taking into account tissue characteristics, you cannot do that based on volume rendering. You really need a 3D model to take that further. Also, of course, as we now also already talked about, 3D printing. This is something that you better do starting from a 3D model. Why? If you have a high quality STL file, your 3D model will also be of better quality and it will prolong for a longer time. Now, I want to bring in a quote of one of the clinicians that we work with, which is Didi Wang, who is director of the Structural Heart Disease Center of Henry Ford in the USA. And what she said is sizing is not enough with traditional CT. What we're missing is computer-aided design, because then you have technology to see depth, angulation, diameters, strength, constraints. And so this is what we stand for. Now, what does Mimics Enlight then give you as an output? It's this. And it's a lot of information on one slide, but we believe it's the most important information that you need to go in your procedure fully prepared and confident. So in Mimics Enlight, we actually have three main goals. First of all, it's getting more insight in the mitral valve anatomy and getting you the landing zone measurements, such that you can go to goal 2, which is device selection, device positioning, and neo-LVOT calculation in an automatic algorithm. And then the last step, we want you to be fully prepared, so we will help you guiding in delivery and defining the fluoroscopy angles that you need during your procedure. Now, you may think, is it difficult? Does it take a lot of time? Well, actually, it is doable. In the mitral valve planner of Mimics Enlight, we have a fixed workflow that you will go through. We have 7 steps, and so you start on the image step. In the image step, you will import your CT data. And when you have that, you will go to the segmentation step. In the segmentation step, you will create that 3D model of the patient's heart. And I say you, but actually it's the algorithm that does it for you. But more on that later. When you have your 3D heart model, you can start assessing the measurements you need. So you go to the landing zone page and you take the measurements that you need. And again, I say you, but it's actually also the algorithm that does it for you. When you have your measurements, you can start selecting the device that you think is needed, the device size, and then you can start positioning it. In every position, you can calculate the neo-LVOT in an automatic way, but again, you will see it also in the software. When you know which device you're going to use and which position, you can go to the delivery page in which you can assess which access point you will use, the mitral height, any angles that you need. Make sure that you're fully prepared. In the fluoroscopy simulation, you can define the C-arm angles. And then when you've done your full planning, you go to the expert page. In the expert page, you have the possibility to generate an automatic report containing all the details you did in your planning. Now, with Mimics Enlight, we also want to take it further than planning. And this is through online case sharing, 3D printing, and virtual reality. With online case sharing, I'm talking about an online platform called Mimics Viewer that we offer to you. And what you can do with it is you can send a link to one of your colleagues that doesn't even have the software in-house, and he can assess all the measurements and all the planning that you made in this platform. So it makes it easy for you. For example, if you go to the heart team meeting, you can pull this up from any computer and you can start digging into the cases that you did. Then, of course, also 3D printing. With Materialise, we have the heart print flex models that have a tissue characteristic mimicking the heart tissue. Now, this is really for the people that want to have that hands-on experience and really want to feel what they are gonna get into in the procedure. You can start assessing your device position, device size, catheter selection, whatever is needed. Of course, if you want to take it more to a technology level, we're also having a virtual reality platform. You just put on your VR goggles and then bam, you have your heart of your patient in place and you can start assessing it. Now, so this was a brief introduction on Materialise, Mimics Enlight. What we will do today is we will go first into a valve and ring case, and then we will dive into a native TMVR case with a Tendyne device. Now, however, on this native TMVR case, I do want to give a disclaimer. This is a beta version. Mimics Enlight is not fully validated for Tendyne yet. We're running a study for that, so soon this will be the case, but such that you already know that. So, are there already any questions?
I think you perfectly set the stage for your case presentations, right? I think we should see this in practice. So I would suggest that you move on with the valve and ring case, and then we can step in if there are questions.
Yes, perfect. I'm gonna hide this one here. So this is a software that I'm opening up. So the workflow that I explained in the PowerPoint, you can see it right here again with the 7 steps. And right now it's open on the segmentation step. Now, the segmentation step is a preparing step, so I'm not going to spend too much time on it today as it is a quite short session. But however, what I do want to give you away is what the principle is behind it. So either you have the automatic calculation with one click on the button, it starts calculating these masks, or you have the manual or semi-automated workflow. What does this mean? As a user, you will give 2 seed points for every anatomy as an input. So the only thing that you as a user need to input are 2 points for every anatomy. That being said, I'm going to go to the next step because indeed segmentation, it is preparing. So when you have that 3D object of your heart in Mimics Enlight, you have 4 options. Either you go for a native, a valve-in-valve, a MEC, or a valve and ring case. You can clearly see that on this case, it is a valve and ring case. So I will hit valve and ring and I come on this page. I will reset this step for you and we get a pop-up saying that we skipped the workflow and you see these steps turned yellow. This is a protection that we have in the workflow. And so what you have right here now is you can easily segment that ring that is in place. So I will give it 1 click and you see right here, my ring popped up. So now I'm fully ready. I've segmented my heart, I've segmented my ring, and I'm ready to start analyzing. I will reset the step 2, such that you can really see what I'm gonna do. Now, for a valve and ring, valve and MEC, or valve and valve, I prefer to do my landing zone in 3D. What I will do for this, I will even hide my left ventricle, which you can see down here in this screen. I will enlarge my 3D screen and I will start placing points for my landing zone. I can use the amount of points that I prefer. I make my landing zone and I close it. Now, I see there is a gap here, so I will add a point. I will move it there. I check it. Maybe this point, I will move it here. So you easily can do any adaptations, and then I hit calculate. And then you get the measurements of the landing zone that you made. So you can see here the perimeter, the area, and then the largest and smallest diameter. Now, if you still want to do Ttabcc measurements, you can also still do them manually. So I can measure my TT, I can measure my AP, and I can measure my CC measurement. I will move this a little bit. So that's it actually for the landing zone. Are there any questions on this step? No
questions, but we have to say that it's very impressive to do all this manipulation in direct live, and it seems to be so easy to use.
It seems easy to use. Yeah, it is actually very easy to use. That's my goal of showing you today. So that's it. Actually, I have my landing zone measurements, and I can just now hit OK. I will then come in the aortic valve step. And in this step, you just need to indicate 3 cusps of the aorta. I prefer to do this on 3D because it's quicker. You can also do it in 2D. It's up to you. Now, why do you need to do this? It is because in the neo-LVOT algorithm of the software, this is the only thing that you will give as an input as a user. We need to calculate the plane perpendicularly on the center line. And for that, we need the 3 cusps. So you see that now we went through segmentation, landing zone, and now we are on the device step. For this case of today, we will use a Sapien S3 of the size 26. What you have is a device library. So you can choose different devices and you can import every STL that is possible. However, you need to run it through the development team of Materialise. Why? The algorithm, it needs to be validated on the devices that you insert, of course. So that makes that you cannot, for example, draw a device or input something yourself, but through Materialise, you can import everything that you want. So I take the cylinder S3. You also see I have the different sizes right here. And there you go. Now, you also, when you start doing a multi-phase assessment, have the possibility to duplicate a device from a different phase. So, but multi-phase assessment is maybe something that we can talk about later, but then you already know you have that possibility. I'm gonna actually reset the step because one thing that the software does is it automatically aligns your device with the landing zone that you've indicated. So the center of your device will be localized on the center of the landing zone. Now for today, I will put this in a 1585 position. So I just put 15 in here and I will hit calculate. And so what the algorithm will do now is it starts calculating my neo-LVOT. And it doesn't take a lot of time. You can see it right here. We have a 378. So I think it's quite good. Now, maybe I want to assess a different position. So I will just put in 20, 2080, and I will hit recalculate. And then again, the software recalculates the neo-LVOT of this device position in this case. So now it's 382. And so I think this is really something important on the device page. You have the flexibility to play around with positions, to start assessing what is the best position and what will be the different neo-LVOTs in the worst case, best case, and really do that risk assessment. Now, you also have the tools right here, translate, rotate, so you can also translate it yourself. So it gives you a little bit more flexibility. So that's also an option. You can also rotate it. So that's what you think is the easiest. Any questions about this?
Do you do this measurement in systole or diastole or both?
Well, normally, right now, the approach that Materialise takes, but of course, we are not a clinician, so I think it's more a question back to you. It used to be first in diastole and then in systole for the neo-LVOT, so diastole for sizing, systole for neo-LVOT. But I have the feeling that right now in the market, it tends more to go to, for example, assess in different systole phases, so 20, 30, 40%, something like that. But I don't know, maybe...
Yeah, this is a very important comment, of course, but because the more dynamic your assessment will be, the higher the likelihood is that you have a correct assessment, because the anatomy and the dimensions change throughout the cardiac cycle. So I think that is a very important notion. And I think at the end of the day, at this point in time, we don't know how important the complete evaluation throughout the entire cycle is. So now we select different moments in the cardiac cycle for different measurements, so to speak. But it is that might change in the future. That might change.
Can I ask you a question? Actually, I have two questions for you. Is it an AI-based algorithm? And the second one, if I understand well, it's a volumetric segmentation here. It's at the opposite of the center line segmentation that we are used to work with. Can you comment on that?
Yeah, so the first question, it is indeed an AI-based algorithm. So what it actually will do is it will seek for the plane that is the smallest by going over all possible planes located on the center line of your aorta. So yeah, can you repeat your second question? It was something about volume and segmentation, but I didn't understand it.
Yeah, I think it's a volumetric segmentation at the opposite of the center line segmentation in your case. Can you comment on this and show the difference? Actually, I think the biggest difference here and the additive value of your model, because I'm working with Michael Forbes, your colleague, North American colleague. And the most important thing, I think, in this case is the volumetric segmentation. And in the LVOT case, it's very, very important. This is at the opposite of other software using the centerline segmentation. So can you comment on that and explain this to our Chinese colleague? I think that will be for a big additive value, I think.
Yes, of course. Yeah, so indeed, it's as you actually saw in the segmentation step, you see these masks that we create of the heart. So I will show you right here. What we will do is we will segment really the blood volume, and we have a volume segmentation. So it is, as I explained in the beginning, you can see the object right here. We really create that volume from your CT scan. Now, you see that here in the device step. For example, when I go to this step, it is hollowed out, but it is really the object of the blood. It also makes that you can do those measurements and you can find those planes really in the volume. Whereas when you do a manual measurement on CT scans, of course, you will never come as close to reality as you can with volume segmentation. Is that an answer on the question?
Yeah, it's a perfect answer, actually. Thank you for your explanation.
Yeah, no problem. So something that I also want to show you, because indeed we don't have a fully 4D model yet. What we do have is a Cine loop function. And I think this can also be useful already because it does give you some insight into the changes of anatomy throughout the cycle. However, it's still in the CT scan. It's not yet in the 3D model. It will be in the future, hopefully. But so right now you do have this function, and you can also see clearly the leaflet motion on here. So I think that this is also very valuable. What are your opinions on this? I'm curious.
I think it's very, very nice to can look at the valve moving. So because the length of the anterior leaflet, I think, has also important implication in the neo-LVOT dimension, because you're basically pushing the anterior leaflet forwards, and that is part of the equation, not just the size of the implanted device. And I want to follow up that with a question that sometimes I want to segment not just the blood pool, but also the tissue, for example, the mitral valve, in order to print the mitral valve itself. So is there any function that can make it more automated in terms of the tissue segmentation?
Yeah, so for the mitral valve, in this case right now, you can see already, you see the anterior leaflet right here. So this is really dependent on the CT quality that you have. Normally, everything that we have on CT, we can capture in 3D. So we have some possibilities already there. Also, when you have clearly your papillary muscles, they can be visible on your 3D model. But it's indeed something that we're ameliorating right now because, yeah, we do feel that need. Something that you can do already, you have some functions right here in the top, is already assess also that anterior mitral leaflet. So you can do measurements like this. You also see it popping up here in the 3D screen. So is that an answer to your question?
Yes. But sometimes the tissue image quality is not so good that, because now what I understand here is just after the hollowing of your blood pool segmentations, somehow in this particular image that the mitral valve becomes visible, but sometimes it's not that perfect, and sometimes we really need to directly segment a mask of the mitral valve itself. So I'm wondering if that and that is sometimes not easy manually. So I just wondering if there is any automated or semi-automated ways to do that.
It is something. I'm sorry, go ahead. There's somebody else talking. No? Okay. Yeah. So we are looking into also getting the fusion with echo, because, on echo, you capture the leaflets the best. And I think that the solution for this also is going to be that we combine a segmentation of an echo image with a CT segmentation. Yeah. But so that's upcoming future. That's not right now yet.
Yeah. You said that depend on the quality of the CT scan. Are there minimal requirement of the CT? Do we need to have a multi-phase CT to have the best performance of your software?
Yes. So we have a protocol for CT scanning. The thing is, actually, every CT that you have, you can import in the software and you can start assessing. But the thing is, when your quality is lower, your 3D model also will be of lower quality and you will have less accurate results. So the best that we advise is to have a 64 slice CT scanner. But I know that some people do it with a lower quality and not with a multi-phase CT scan. So it depends on how accurate you want to go. The more quality, the better. But you can also, I've had already also CT scans in here that were from lower quality to still have some insight in the 3D anatomy. So, yeah.
But then it becomes slippery, of course. So I do believe we need to encourage better quality CTs rather than working with second best data. It is you have to look at it from a patient perspective. If we are planning very complex procedures, you better do proper planning and use proper quality scans, for sure. But Winthe, for my understanding, I thought this Cine loop was quite impressive, that you could appreciate that movement of that anterior leaflet. Can you do the same loop with a device in situ?
Yes, of course. Right now, the device is just hidden, but if I pop it up again, you can.
And then see how that leaflet will behave. Can you... And is that a reliable simulation then?
So the thing is, the device positioning right here, you see that the device is rigid. So the device is not moving with the heart. So that's something you need into account. The device is placed like you place it and it stays in place right there. You can also see it here. So the only thing that's moving here is the CT data to give you more insight in the in the motion of the heart. So yeah, so that's important to notice. So if you place it lower or higher, it will stay in that other position.
So what we're now seeing is the leaflet of your bioprosthesis. It's not the native anterior leaflet.
No, you see the native anterior leaflet. Yes, because it is from the CT data. So if I hide my device, You just have the...
But basically what you don't have is that what the result is after the device is implanted, because of course you push away that anterior leaflet and it can no longer have this systolic
excursion.
Yes.
Yeah.
No, of course.
So that should be, that would be of interest, of course, if you could simulate.
Sure.
Sure.
Right.
In real life.
But this is future.
I know, but that's what we're doing. We're looking at potential future.
We have to say always future is now, so we have to push.
It's the same with the previous technology. Yeah.
And after this, you will have to simulate the lampoon. Also.
Yes, that's also true. Yeah, true. However, I do want to say that it does give. I think it's more also for you to, imagine and visualize and try to assess how it will move there. And so you could do like some spline indications or something like that. But indeed, the leaflet, how it will be after implanting the valve is not something we can do already.
But to be honest, as I have some expertise in AI, but the solution is to fusion segmentation of 3D echo imaging with CT segmentation. And this is the way to go. But I know very well it's not easy to do so. So this is your mission in the next years to have this for us as an implanter, because that will help a lot, because we will characterize the tissue, mitral valve tissue, aortic valve tissue, and this will give us a very additive value and help us to plan our cases, I think.
Yeah, I completely agree on that. And it's also something that we're working on. So hopefully future will become reality soon enough. So yes. Now, for sake of time, I still want to move forward because we also still have the other case. So after the device step, you also have your delivery step. The input that you give as a user is your fossa valens and IVC. So it's 2 points that you will indicate manually. You can do it on CT or on 3D. And then the software will generate a delivery pathway for you based on these 2 points. So in delivery right now, nowadays, we can offer you a lot of measurements and angulations, but the question is still there, what is useful for you as a clinician? So mitral height is one of them, but it's already, I want to point out to you what you can do in delivery. You can play with this curve, and then you see the measurements pop up. So I'm curious here also about the comments you have on delivery and what your opinion is on what is needed in pre-planning there, because I believe it's very clinician specific also. No comments?
No comments.
No. I guess you can potentially adjust your transeptal location depending on your case, on what you're doing. So having these kind of measurement, you can potentially plan your transeptal to reach the mitral valve in a good position for your procedure.
Yes,
so I see value of that. See, you can potentially say I will go higher in this case. Turn 90 degree after a few centimeters to reach the valve in a good position to deliver my new valve.
Mm-hmm. Okay. Yeah, indeed, that's the goal. Yeah. Thanks for commenting. I will move now to the last step of the export, and that is the fluoroscopy step. So in the fluoroscopy step, it's really the goal to simulate the angles that you will need. Now, I think it speaks for itself, the principle behind it, so I will not spend too much detail on it. I want to show you how flexible it is, so you can put in every angle that you want, and then the fluoroscopy simulation will adapt to it, and you get more insight to it. So I will maybe put it in a 40 LEO. If you have specific angles that you use or something, you can assess them. You can play with that around. You can hide your device or you can show your device. you have a lot of flexibility in this tool. Okay, so any questions more on this case? Because otherwise I will go to the next one.
Actually, I think we have just 2 minutes for the session. So if you can go directly to your last case, that would be, I would be very grateful.
Only 2 minutes. Whew. Okay.
Yeah.
Sorry, but yes.
Yes, I will highlight the most important things. So what I want to tell you about is on the landing zone step, we have an automatic landing zone calculation. So it's already done right here. This is based on statistical shape modeling. So based on other patients from the population of mitral regurgitation, a landing zone is created automatically. Now, for 10-9, they rather use a D-shaped landing zone. So I'm still going to show you that, how you can do that, such that you know that you also have that possibility in Mimics Enlight. So I'm going to align my MPR to the plane of the mitral valve, and then I will indicate my D shape. So again, it's the same principle. You click the amount of points you want to use. I double click, I hit calculate, and then the software gives me the measurements back of this D shape. You can then also still do your TT measurements. It's now not fully correct, but it's just for demo purpose. And then you hit OK. It's the same aortic step. And then you go to the device page. And now the difference is before you chose, for example, the Sapien. Now you can choose a 10-9 device. And so also hopefully in the future, you can go for Intrepid or Sophia or whatever device you want to use. Now this step might take a time sometimes because it is a big case. So you can see here right now, I choose the 10-9. And this is actually the patient of the live case of today. So it's quite exciting. And so it's a 33S valve that they're going to implant. You can see it's already in position. So I will just hit recalculate for you to see how the neo-LVT algorithm works. Also, it's the same as before. You also have the cine loop function here. So you can also assess the motion of the heart with the device in place. But again, it's the same. Yeah, and also this is the beta version as I explained to you. So it is possible that it gives some problems in calculation, but then you already see what is possible. So come on.
So this step assume that the mitral annulus is a planar structure, but in reality it's a non-planar structure with a saddle shape. So right.
Yes. So that's a little bit the difference. This is something that we need to investigate more. You've seen the automatic landing zone measurement does take into account the saddle shape. So that's something that we stand for because it takes more into account the value of 3D. However, every medical device company does their sizing very specific to their device. And so for 10-9, they use a planar D-shaped structure. So that's why I also use the planar D-shaped structure now, because otherwise you cannot use the sizing charts. But yeah, this is something we need to investigate to see how can we map the 3D saddle shaped structure on device selection and device sizing.
Because in the echo field, we have quite good automated software that can segment the saddle shape of the annulus. So you mentioned about the fusion with the CT and the echo. Maybe that would be the future way to go. So using the echo to segment the annulus with all these, giving all the measurement. They can also give the planar measurement after segmenting the saddle shape.
Yeah. Yes, I do think indeed that's future. Yes. Okay, so I guess time is up.
Yeah, Winthe, thank you very much for this.